Hello, everyone. Welcome to our webinar, Without Our Consent, Centering People Living with HIV and HIV Genetic Sequencing. My name is Brian Minalga, and I'm with the Legacy Project. And the Legacy Project focuses on building trust and collaboration between HIV research institutions and the communities bearing the greatest burden of HIV in the United States. So we're really looking forward to the next three parts of the webinar series. The second one coming up in April is more about the research, which Legacy focuses on. But the topic of today's webinar as part of the four-part series is all about centering people living with HIV and genetic sequencing. I'm just going to run through a couple housekeeping items before we hand it off to our speakers. Today's webinar is being recorded, and you can access the recording and the slides by following the Legacy Project on Facebook. So you can see us there at Hank Legacy Project. And in just a moment, I'll type that into the chat box so you can just click on it and follow the link and like our page right away. There's also a brief survey following the webinar. If you could complete that, that would really help us. And lastly, this is meant to be a participatory and interactive webinar. So you can communicate with the presenters by typing your questions and comments into the chat box in the lower left-hand corner of your screen. And before we take it away, I just wanted to take this moment to recognize the presenters on the webinar. It's my great honor to introduce Chris Sardina from the Desiree Alliance, who will be sharing with us about the sex work community and molecular HIV surveillance. Robert Suttle from the Zero Project, who will be sharing more about HIV criminalization. Marco Castro Bojorquez from Venas Abiertas, who will be talking to us about the Latinx community. And Octavia Lewis from Positively Trans, representing the transgender community. And we also have two moderators today, Dr. Andy Spieldenner from the U.S. People Living with HIV Caucus, and Vanita Ray from Positive Women's Network USA. So with that, I will hand it off to Vanita.
Okay. Can you hear me?
Yes, we can hear you.
Okay. Thank you, Brian, and welcome, everyone. It's so interesting. I forgot this was a webinar. You didn't see me, so I put on lipstick that y'all can't see. So just know that I have it on, okay? I welcome everyone to our the first of our four-part webinar series entitled Without Our Consent, and really want to thank our partners and folks that are here. The reason for this webinar series is because there's been a lot of talk about molecular HIV surveillance and the science behind it, and we really jumped at the opportunity to provide more community education on this, and somewhat new, but it's been around for a little while, national surveillance approach in the U.S. Some of you have heard them mention this in the recent ending the epidemic talks from HHS. So there's going to be a series of four webinars that Brian referred to. The first one being that's going on today, Without Our Consent, and we're going to bring you a few different perspectives from different communities that tend to be marginalized from people living with HIV perspective from those communities and the impact of this type of surveillance on those communities. In April 18th will be, and April 25th will kind of take the research kind of perspective, and those two webinars will delve into conversations with someone from the National Institute of Health and myself. As a matter of fact, on the 18th, that is called These Trees Cast No Shade, Understanding HIV Phylogenetics Research. And then on the 25th, we'll be doing one called Understanding Molecular HIV Surveillance from a Public Health Perspective and looking at the public health and human rights implications. And there will be a conversation between a CDC official and one of our community leaders who happens to be Nana Khanna. And then the last webinar we will be doing, we'll be looking at talking kind of a community forum about what will be the community action. Is there an action that the HIV community wants to take? And so we'll be looking at, cluster, folks call this cluster tracking, but the fail to realize is really people tracking. So there will be our version of a community town hall on molecular HIV surveillance where we can talk about our concerns, put together plans, and talk about next steps for our community on molecular HIV surveillance. So I hope you've registered for all four. This really proves it's going to be really an exciting series. So next
Thanks,
slide.
Anita. And before I go to the next slide, a couple of folks are just saying sometimes the audio is just a little bit choppy. So just for all the presenters to make sure to speak right into the receiver if possible. That should help a little bit.
Yeah, and I was getting an incoming call that I was ignoring. Sorry about that, folks.
Okay. All right. No problem. Here we go. Next slide.
And just so you know, it takes a village, right? And so we wanted you to know that this webinar series is a partnership between the Caucus, Positive Women's Network, the Legacy Project, and Brian's great coordination, the Cyril Project, Thrive FS, the Union Project, ICW North America, and our friends at Positively Trans. So we couldn't do this without you all, and thank you all for your support. Next slide. So this is an opportunity that you get a chance to participate in a poll question. And the question will be, and you'll be able to input on your computer if I'm not mistaken, is this a new, how much do you know about molecular surveillance? So you get to use your computer and you can check nothing, just the name, very little, some, quite a bit, or if you're an expert, let us know, and then submit. So we'll take a few moments and let folks take the survey. We just want to get a sense of who's out there, who's on the line, and so we can better address the needs of the community. So Brian, you can let me know when where we at on that.
Yeah, we're at about 40. We'll give it another minute. And just to let folks know, we're joined today, it looks like, by about 60 folks on the line. I know there's a whole group of folks in Mississippi watching together. We even have one of our speakers is overseas, so thanks everyone for joining from near and far.
Yeah.
And we're at about 40 responses, so we'll go ahead and submit that.
Okay, thank you. Will that come up with a response for me?
Okay, you see the responses there?
No. Oh, there they go. Okay. So what it looks like is, there was a small percentage, 9% of y'all that know nothing, which is great. You're in the right place. We have about 19% of y'all that know very little. Quite a large percent that know some, which is 45% of you that have some knowledge of molecular surveillance. And then we have 19% of y'all that know quite a bit. And then we got 7% of y'all that are experts. And that's be interesting. I'd love to see who the experts are here. But that's a wide range of folks, so thank you all for doing that. So what's going to happen today, we're going to talk a little bit about molecular HIV surveillance according to the CDC.
Benita, I can take over from here and pass it back to you if you want.
You know what? As I was reading this, take it away, Andy. Thank you.
Okay, I apologize, people. I'm actually on the streets in Geneva, and it's at night, and I apologize for that. I've had a really weird day traveling, and I'm here for a meeting at UNAIDS. But I will try to do my best to participate, and thank you all for coming. It's been really great to work on this project, and thank you, Brian and Benita, for partnering on this along with everyone else. So the CDC, put out guidelines for molecular HIV surveillance, and it's a new kind of surveillance for HIV. But molecular surveillance itself has actually been used in lots of other diseases, including tracking foodborne infections and tuberculosis in the U.S. And it's been incredibly important in terms of being able to identify where there are gaps in the healthcare system. So in the spaces where we've used this, where we've seen it used successfully, it's really shown kind of like whether people are identified early on, whether they're tested, if they're able to access treatment, if they're able to maintain their treatment. And this is one of the things that's really exciting about it. What it does, though, is it takes our HIV genetic sequences that is generated through our HIV drug resistance testing, and I'll walk through that in a minute. I do want to point out that the current science doesn't determine directionality. What it does is it examines how close you are in a molecular cluster. So the closer you are in a cluster, the more likely you share the same HIV strain. And this would allow for health departments to identify transmission clusters that they might not otherwise recognize, and be able to tell that people are within a the same sexual or drug using network. Next slide. So this slide is about how molecular sequence data is collected, and the first thing that happens is, as people with HIV, part of our standard of care is that when we present in the clinic and require new HIV medication, whether you're newly diagnosed or whether your viral load is no longer being suppressed or there's some other issue with your medication, the first thing that happens is your clinician is going to send your blood in for resistance testing. And that is a genotypic testing, so it's looking at the molecular genotype of your viral strain. So it's sent to the laboratory, and you see there the chart. It goes down to the chart. That's the sequence. And two things happen. The resistance is reported back to the provider, and the other thing that happens is that the HIV sequence is electronically reported to the health department and sent to state and local health departments and CDC. Now, a really important thing to keep in mind is when it leaves the lab, the data is anonymized. When it goes to CDC, it's anonymized. So at the federal level, they're only looking at genetic sequences. There's no other personalized information connected to the blood sample. After the cluster detection is determined, after it's determined that there are people that are within the same cluster, then there's a prioritization process to determine if this cluster is recent, whether it's active, and this can be shown in the number of people that are present in a cluster within the same year or two. So because what happens often is that when we don't know our HIV status, often our virus is not controlled, and we're more likely to transmit at that point. So what happens is a lot of these are recent or new diagnoses, and they're able to be clustered that way. And again, this is a public health intervention that happens, and then what happens is the data is sent back to the health department with the cluster identified for their intervention. Next slide. So one of the reasons why we're concerned is this guide for health departments came out in June 2018 and was conducted with a bunch of experts, but none of the networks of people living with HIV were involved. And it concerns us because it's our biological sample that's being used. One of the things to keep in mind is that because this is being used for surveillance and it's anonymized, it's totally legal under U.S. law, and it's totally ethical under U.S. law to send our data in. So we don't give consent, which is the title of this webinar, because at some levels we don't have to for surveillance. It is technically a public health good. So I want to keep that in mind. But one of the reasons why we're concerned is often when we look at communities of people living with HIV, we have a lot of other issues that make us marginalized and vulnerable. I'm sorry, is it too loud where I am?
No,
Right. It
I
sounds
think
fine to me.
Okay, sorry, I'm trying to. And so that's one of the reasons why we're concerned. And this webinar is really to help us reframe this discussion from a community viewpoint. We understand the public health importance of it, but we wonder about whether public health has understood the community impact. So after the cluster has been identified, next slide, these are the various things that can happen next. The cluster is identified to the state health department. This is then put into the partner notification system where disease intervention specialists identify the cluster, the person. So the data is de-anonymized at this point so they can do the partner notification. Hopefully that leads to linkage to care and a broader testing of a risk network. So ideally the disease intervention specialist comes to the person does a successful partner notification, links them to care, and is able to test people in their risk network, and potentially could have additional funding to the state health department to deal specifically with the prevention issue. Larger, this does enhance state and local jurisdiction health departments in terms of their surveillance capacity. And that's roughly the science. And again, I'm not an epidemiologist, but it's what I've come to understand about the science while I've been studying it. And this is the ideal kind of public health modeling. So there are some gaps here, obviously, but one of the things that we wanted to do in this webinar, and Benita can take over from here, is to really talk about not the public health good, but how this could be experienced with various communities. So with that, I'm actually done with my bit.
Oh, no, you're not. Okay, next slide. Hopefully, I've put on some earphones. Hopefully folks can hear me a little bit better.
Yeah.
If not, let me know. Great. So thank you, Andy, and you ain't done yet. You know, we got work to do. We wanted to speak a little bit about the kind of differences of public health surveillance is permitted to partner with law enforcement in the U.S. And so that's one of the areas and why we have concern that sometimes the public health overlaps and with law enforcement in the U.S. In other countries, public health data is kept separately from law enforcement. But in the U.S., one of the powers of the health department is the ability to utilize law enforcement when there is a threat to the public health or the public health is threatened. And so it tends to justify use and communication. And even though folks say we're not sharing information, and there's HIPAA and all this, state laws really govern how law enforcement a lot of times communicate with health departments. For disease intervention specialists, it could include use of law enforcement to identify individuals as well as to force partner notification. And even if it's not forced, folks still force. So it has the same impact in some instances. So
one of the things
go ahead.
Oh, so one of the things I wanted to highlight here, and I'm just going to disclose this, is I've been part of 2 investigations for syphilis. And in both cases, the disease intervention specialist threatened me with police within 20 minutes, threatened me to get the police to force me to give names. And so this is, and, I'm, relatively, comfortable with yelling at people. And even then, this person, in both cases, the person threatened me with police within 20 minutes. And for me, that's not a worst case scenario. That's probably, depending on the jurisdiction you live in, might be an everyday scenario or a regular scenario, depending on the training and the ideology around the people that do disease intervention work. And I'm not saying that everybody, like there's some jurisdictions that work really well with their local communities. I live in San Diego now, and one of the things is that San Diego piloted molecular HIV surveillance 10 years ago as a partnership between CDC and UC San Diego. And, the local health department has an amazing relationship with the local HIV community. So in that case, it would never occur to them to use the police or threaten with the police. But where I've lived previously, it was like the second thing that they went with. So that's one of the reasons why we wanted to kind of frame this, is because how quickly some people feel comfortable threatening with law enforcement. Next slide.
No, thank you. Next
slide.
Sorry,
do you have anything there? Okay.
Yeah, no, I think you captured that perfectly. So some of the characteristics of molecular surveillance identify clusters. Remember, clusters are people thus far, and hence we're getting ready to turn this over to our panelists. The folks who are experiencing this the most are people of trans experience, our Latinx gay men, people who are homeless, people who inject drugs, and members of the African American or Black community. And these are already communities that are experiencing increased surveillance and policing from a lot of other aspects as well. So how then do these communities experience policing and law enforcement? And so we have a panel here that is going to share with you a little bit about how policing and law enforcement are felt by these communities. And so our first panelist is my friend, representing the Latinx community, Marco. And I'll hand it over to you, my friend.
And actually, Vanita, before we pass it to Marco, there are a couple questions just for Andy before Andy, I know, has to take off. There are more questions actually than we have time for right now. We might be able to get to some of them later. I'm just going to choose the two that seem the most clarifying. So probably for Andy, there's a question here. Who de-anonymizes the samples that go to the CDC, and then who re-anonymizes the data after the molecular analysis is completed?
So this is, I believe it's done through a computer. It's not done through a person. And then the challenge is that the sample has to be reconnected to a person's identifying information in order for the disease intervention specialist to actually identify who that person is. And so that's one of the ways in which at the federal level, CDC is correct. They do not have any names attached to this data at all. They do not keep it. There's nothing they're concerned with. What they're concerned with at the federal level is helping health departments be able to identify where HIV transmission is occurring and what the characteristics are of that network in order to best do HIV services and get people into care. So I believe that everything happens through software.
Okay, great, thanks. And then the last question before we need to move on. First a comment actually from Kamaria and then her question. Just Kamaria is reminding us that this is not something on the horizon. It's been happening for some time now. And the question is molecular surveillance legislated or just something designed by the CDC?
So this is a science that's being used globally. There are different countries that use it in different ways. We've been using it again with foodborne diseases and with tuberculosis for a long time. So this is not something that's necessarily something that is something CDC's. It's not legislated. But I will say that the surveillance has already been, you're right, this has been happening for a while, at least a year, or something close to a year. No, it's been over a year that it's been federal.
Yeah.
Different jurisdictions have been doing it for different amounts of time. Like I said, San Diego's been doing it for over 10 years. But this has been happening for at least a year. It's been part of the surveillance funding package for over a year. So every health department that gets HIV surveillance funding also has funding for this and is required to engage in it. Different health departments have picked up on it at different levels because of capacity and because of their community engagement processes. So some health departments have slowed down how they're doing this because they're trying to engage the community more before they roll it out fully. Other health departments have jumped into it and are already really aggressively using this. Where you live, Brian, in Seattle is an example where it's really aggressively done. The other element of it is that in the federal and the AIDS epidemic, the fourth pillar of the plan is actually molecular HIV surveillance. So I don't expect this to go away. I do think we need to have a community-engaged conversation about what our needs are in the HIV community. And what we're afraid of, so that we can be proactive in getting health departments and CDC to help to listen with that and to find the best tools possible to serve both the public health need and more importantly to me, our HIV community.
Yeah.
Great.
Well said.
Well, thanks for those responses. Andy, I know you have to get going, so thanks so much for joining. And for the folks who have been entering questions, keep them coming. I have a feeling we might run out of time to answer all of them, but if you keep typing your questions, we can at least email them to the presenters and get you some responses later if we can't get to them all.
Thank you so much, everybody. I'm sorry, I'm on the street.
Thanks, Andy.
Okay. Bye, everybody.
Bye-bye.
Okay, Marco, the floor is yours.
Okay, can you hear me okay?
Yes.
Yes, perfect. Thank you everyone for coming to our webinar series, and I hope that you sign up for the rest of the series, and as we are going to end up with a town hall of sorts. And for me, it's really important to be part of this conversation. I came to the U.S. basically running away from violence in my country, in Mexico, and it was in the mid-90s. And in all honesty, very little has changed on regards to HIV. Even with today's evidence-based tools for treatment and prevention, our Latinx immigrant community is simply not included. As a queer immigrant person living with HIV and struggling with mental health issues, I am often invisible, except when I am being discriminated or attacked. In the past 2 years, I have dealt with serious depression issues, and and I was homeless for some time, jobless for some time, and heartless for some time, or hopeless for some time. But I have continued doing work with the HIV community and the HIV movement, and that has kept me active. And so, for me, one of the issues that I noticed in the movement is that Latinx people are very few in between. There is no leadership development that is targeted to Latinos or Latinx people. And so when I learn about things like molecular surveillance and think about the over-police that we already are the target of, amen from the attacks by the administration, separating our families, killing our transgender sisters in detention, and taking away DACA. It's the amount of tax that we experience on a daily basis is sometimes really difficult to deal with, and on top of that, we struggle with the stigma and other issues regarding HIV, like people who don't get tested, and I think that the reason for that is because the environment that we live in is hostile, to say the least. And so I'm going to move on, and what I'm going to do is that I'm just going to remind you also that the reality of Latinx people living with HIV or affected by HIV is quite difficult because we are the group that is doing the worst, actually. But Brian, let's go quickly through the slides where I got some inspiration from this great new report. I think it's a policy briefing. It says, being Latinx in the United States means being part of a diverse and vibrant community. It also sometimes means being subject to discrimination, marginalization, and hostility. And then the other quote says, being gay or bisexual in the United States means being part of a diverse and vibrant community. It also sometimes means being subject to discrimination, marginalization, and hostility. So I thought that was beautiful. So the numbers are basically, most of you know the numbers. 1 in 5 new diagnoses in the U.S. in 2017 were among Latinx, gay, and bisexual men. Those HIV diagnoses among these men increased by 12% from 2012 to 2016. And then from 2010 to 2014, 84 of the increase in diagnosis observed among Latinx, gay, and bi men nationally was attributed to places only in Puerto Rico, and the states of Arizona, California, Florida, Illinois, New York, and Texas, or Texas. And next slide. So from 2011 to 2015, the rates among Latinx, gay, and bisexual men they increased, and increasing diagnosis while declines are seen in other groups like among our Black brothers and sisters. In the up to 40, so in the Latinx community, the increase on diagnosis was up to 14% in all ages, 19% on ages 13 to 24, and 21% on the ages of 25 to 34. During the same period, the diagnosis declined by 16% among women and stabilized among Black and gay and bisexual men. By no means I am diminish the devastation that our Black brothers and sisters are experiencing, I should say. I think that these are all the numbers, right? Right, Brian? We can go to the next slide. And I'm sorry if I'm rushing, but I wanted to just, the numbers, I think that it's important for us to remember that if current trends continue, 1 in 5 Latinx gay and bisexual men will be diagnosed with HIV during their lifetimes. That's a lot of people, Next slide, please. I also wanted to make the point that Latinx transgender women and men are highly vulnerable to HIV and often have large unaddressed HIV and other healthcare needs. Latinx transgender people are an important part of our Latinx LGBT community. And I often see how studies, research concentrate on gay and bisexual Latinx men because those are the folks that are that in numbers are insane. And so I think that but I also adore my transgender community, and every time that I can actually make the point and highlight that they're also part of our community is really important. So now let me land the plane into molecular surveillance in the Latinx community. And so what I did is that, and Brian, maybe you can give me a time, but what I did, folks, is that I sent a couple questions to my friends. About 10 of them responded, and I want to share with you. I also want to share with you that I see HIV surveillance as something that could be very positive for our community, but I also have observed how the CDC has conducted themselves without really taking into consideration the networks of people living with HIV that I'm part of. And so it's kind of difficult to feel included in something that affects you very, very personal. So I asked a few questions to my friends and colleagues. The first question that I asked them is how do they easily will describe HIV molecular surveillance? And I'm going to give you just a couple of answers. One person says, I will describe HIV molecular surveillance by saying that the CDC is illegally checking on people who got tested and have a positive results and pass the virus. That was one of the responses. And then another person said that that HIV molecular surveillance is a CDC-mandated surveillance intervention for health departments in which individual HIV genetic data is used to contain HIV outbreaks. And then the third person that I want to share with the response said that it was a desperate way of government to make up for the failure on prevention efforts, which I thought, it wasn't really far from the reality, especially because I actually have visited health departments in the U.S. and I have learned that undocumented people are not accounted or included in this process, which I don't know if it's good or bad. Honestly, I think it depends. Then the second question that I asked my friends was, what are your concerns with molecular surveillance in the Latinx community? And one of the answers was, my concerns are that people that are undocumented, it will continue to get deported. And it will be also lack of funding for our Latinx community. Another person said, surveillance of migrant communities forcing more folks to go underground and not access services, which is very true. And then somebody says that I am concerned that aren't enough protections for our Latinx community already. To confidentiality protection, although confidentiality protections exist, it does not mean the information will not be concerns of our Latinx community while we're being called rapists, murderers, illegals, and being separated from our families and experiencing other human rights abuses. And lastly, I asked a last question, and I asked them if there is anything that, actually there is two more questions. I said, is there anything that you want me to include about this issue that could be relevant for the webinar participants? And the answers were, one person said that it would be good for us to talk about how to translate science to who is going to use it in the community and what it means to them. I love that quote. Another person says that molecular surveillance is not new. It has been used in public health to continue stopping the spread of HIV. It is an effective scientific tool. If public health uses it appropriately and with respect to all, it should not have a social implication. And then the last person said, the Nazis made great scientific advances in science, but they used to oppress people. They can easily end up like that. I want to point out in this quote about Nazis that, at the beginning I thought when I would hear comparison of our government to the Nazi regime, I would just think that it was a little too much. But after seeing what has happened in the past 3 years, it honestly, it just doesn't sound so crazy anymore. And so some of us are scared, some of us are, sick and tired, and then so now we have an extra thing that we need to worry about, which is, Latinx people are going to be less inclined to go and get tested or get treatment or talk about HIV. And so, and on top of that, undocumented people don't have access to healthcare. So I don't know how you're all gonna end the epidemic by 20 whatever. So the last question that I asked my community was, what good is in it for the Latinx community when it comes to HIV molecular surveillance? I thought that a couple of thoughts was worth sharing with you. One person says, I think this effort holds promise in finally addressing the late diagnosis many Latinx community members experience. Not much has been done to truly address this, and we see the ramifications in our inaction. The confluence of having such a threatened administration makes the good which could come from this much more difficult to realize. Another person said, if the data collected is protected by the law and the added potential stigma addressed, HIV molecular surveillance could potentially help Latinx communities to get needed services to assist with HIV. And then the last person said, Latinx community bicultural behavior do not prevent any illness. So HIV molecular surveillance can identify risk networks that are concentrating for poor health outcomes, such as transmission in this particular underserved population. And that concludes basically some of the thoughts from my community in the HIV movement about, we are concerned, in summary, we're concerned with the over-policing that already exists in our communities. I experienced something really horrible this December when I was coming back from UNAIDS, where I spoke about mental health. And they basically detained me at the airport and asked me questions like, how did I contract HIV? Was I a drug lord because I'm from Sinaloa, Mexico? I was asked if I have the HIV Power Shift logo with me, which is an American flag upside down with schools, and they told me if I was. They asked me if I was a terrorist. So I was very surprised. I never felt, the immigration people have questioned me before, but I never felt what I felt this time. And I was not able to continue my life for a few days because it was kind of traumatic. So we are experiencing over policing from many ways or aspects in our society, and so I am concerned because of that, and I am concerned because they haven't consulted with the Latinx community at all, and so I hope that this is an important step to a productive dialogue where communities are included and they are listened to. Thank you.
Wow. Thank you, Marco, for sharing that and bringing the perspective of the Latinx community and that experience that I know you went through last December. I appreciate your willingness to share that. Wow.
Thank you, Nida. Thank you for your work.
Thank you. Brian, I'm going to go to the next panelist unless you have a question, but we may be running behind in time. So, great. I'm really happy to introduce my other sister in the movement, a woman I idolize to know just all over the place. She does fabulous work, and Octavia Lewis. Thank you, and the floor is yours.
Thank you, and good afternoon, everyone. Again, my name is Octavia Lewis. So our portion, again, is Molecular HIV Surveillance and Criminalization of Transgender Individuals. But before I go to the next slide, let me just make sure that I make everyone aware that 1 out of 2 African American transgender women is living with HIV or were contracted in her lifetime, and 1 out of 3 of our Latinx sisters is living with HIV or will contract HIV in her lifetime. Next slide, please. So, the typical surveillance reporting cycle. This is how it should go. Again, if it's not impeding with law officials, again, meddling in the surveillance process. Normally, the patient receives their HIV diagnosis when they go to take their HIV test. The patient presents for care after they, again, receive their HIV diagnosis. Then the physician orders a genotype just to see anything that they are going to be resistant to see what type of medication, or see, what type of regimen that would be best suited for them. Then the genotype is processed at a laboratory, and then the laboratory reports are sent to whom. And that is where the question mark comes in. Because again, as Benita stated earlier, the United States government is one in where the health department and local, state, and federal officials oftentimes intersect with one another when they should be mutually exclusive. Next slide, please. So the current surveillance of transgender individual study. It looks specifically at transgender women in these networks to see how they were connected to other population groups at risk for HIV transmission. The analysis found that transgender women were more likely than expected to be in similar transmission networks with heterosexual cisgender men, and less likely than expected to be connected to men who have sex with men, MSM. This method was utilized in a manner which will aid the department in finding others who might have been exposed in the same way they were. The cluster data could allow health departments to prioritize individuals to interview by helping them understand which sexual networks are most likely to include undiagnosed transgender women. Next slide, please. So, our concerns are it would increase the chances of our statuses being outed if the potential person shows up in their sexual cluster, meaning if we are located within a certain zip code or a neighborhood, and say, for instance, someone goes to get tested, and again, the using molecular surveillance, um, the person might ask them, well, who are your sexual partners? And because they may be having intercourse with women of trans experience, they might not be likely to out themselves with that. So in turn, that person or that healthcare provider could be like, well, let's just say we did your genotype, and what we found was that your particular strand of HIV that you have, was also found in, let's say, a zip code of 10457. So this person in turn can say, well, wait a minute, I know what neighborhood that encompasses. So if I know if that strand is coming from this neighborhood, then it automatically means that I must got it from this person. That was a concern for us. And another concern was the increase in the likelihood of those opposing decriminalization of sex work to use the science against the community. So we were afraid that, again, for those local, state, and federal municipalities to say, well, look, this is a reason why we should not decriminalize it, because these people are sexual deviants, they're coming into our neighborhoods, and look at the science. They're saying that all of it is conglomerated within an area or a zip code or within blocks in which these people work, reside, and live in. So that was one of our concerns. Our next concern was the increase in the chances of other states utilizing the data if convicted of escorting in another state. Now, for those that do not know, it is not always easy for women of experience or men of experience to just go and apply for a job, because there are certain municipalities that do not have laws on the book to protect people of trans experience. So in turn, what we have to do is to again turn to escorting to survive, and sometimes that takes us across state lines. So again, we didn't want the likelihood of someone testing positive in a state that again has harsh criminalization laws, but even though they may live in another state, and that following them. Another one of our concerns was the increase in the likelihood of states that have not modernized their HIV statutes to prove that this is why they need to be strengthened. So what we were, again, afraid of was legislators saying, well, look, you people are arguing that we need to, again, weaken our laws or take some of our laws off the book with those people that are HIV positive. But what we're saying with this data is that these people, which talking about people that are HIV positive, are living within a certain area, and now we have people that are popping up positive, and it all being linked back to this certain area. So that was one of our concerns. And last but not least was the increases in the chances of the data being used against our community by hostile local and state municipalities opposing equal and equitable rights of transgender people. So for those that may not be aware, we face oppositions on all fronts, not just in the HIV community, but again with those that want to serve in the military. We're still having issues with those that just want to use the bathroom in peace. There are certain states that, again, a person of trans experience cannot even use the bathroom in peace. And again, with the high threats of violence against people of transgender experience, again, last year we had a total of, that were documented, 28 women of transgender experience that were murdered. And looking at the proportion or the size of our community in comparison to how frequent these murders are happening in our community, this is another one of our concerns on, again, having this type of information out there and being used against our community. Next slide, please.
I think that is it for you, Octavia. Next is Chris.
It's Chris.
Okay.
All right.
Thank you, Octavia. I always learn so much when I listen to you. There was so much that we could unpack in your comments. I so appreciate your willingness to share.
Thank you for having us.
Oh, my goodness. And now another sister from another mother. We're going to get a perspective from the sex worker community from Chris Sardina.
Okay, can you hear me?
I can hear you.
Okay, next slide. I do want to, I'm Chris Sardina. I'm the National Director of Desiree Alliance. We're a sex worker rights organization. And it just seems to me that that's all we do is we fight for our rights. We never get any. I can't even piggyback hard enough on what Marco and Octavia are saying in their slides. Characteristics, I want to go back to the characteristics of an earlier slide of MHS identified clusters. People of trans experience equals sex work. People, Latinx gay men equals sex workers. People who are homeless equals sex workers. People who inject drugs equals sex workers. African American equals sex workers. We fall in all of these categories, yet we are not a category in and of itself, which might be a good thing. So I really enjoyed the first two speakers, and thank you so very much. Recently, laws stacked upon laws affect sex workers. Interpretations of laws fall onto state, local, federal enforcement agencies and health departments. HIV laws and sex works can be enhanced to felonies for ordinary misdemeanor charges. So is clustering, I mean, I really want to piggyback off what Octavia was saying, is if it's in an area, you know, I'll just go on with this because I could rant on and on all day about it. But identifying clusters and mining it for beneficial gains, they're not going to look at, will not look the same for all communities. Highly policed areas will be subject to targeting. Many stories of law enforcement targeting known HIV-diagnosed sex workers, taking their meds and smashing them on the ground, disclosing medical histories to other sex workers, arresting clients and disclosing HIV status of sex workers, law enforcement violence against undiagnosed and diagnosed sex workers, criminalizing harm reduction methods such as condoms, needles, things like that all could stop the transmission of HIV are criminalized for sex workers. Incarceration violence when status is disclosed by law enforcement. If you're incarcerated and law enforcement knows this, because people will disclose their HIV status to them so they can get linkage, you know, to meds and things. So, I mean, you know, these are all the things that are used against sex workers. And sex workers with HIV, it puts them at a double risk of danger, and this is just through law enforcement. So this is the laws stacked upon laws that affect sex workers. We've got the Mann Act being used against us. The RICO Act has reared its ugly head. And so I'm thinking, you know, there were 300 laws against sex trafficking, enmeshing it with consensual sex work. So sex workers are really starting to see already highly criminalized, already highly criminalized, even becoming more criminalized. So, you know, all these are a real concern on the sequencing and how it's going to be used. Next slide, please. Skill sets of health departments and law enforcement agencies are not equal. Some are funded well, some aren't. Some have, how will sequencing and databasing begin? I mean, this is my big question. Arrest, targeting, profiling, how is this going to affect communities like the sex workers and trans communities and people that are not papered here in the United States, you know, to freely roam about. So these are the problems that we're seeing. What methods are in place to ensure criminalization will not occur? Has the CDC thought about this? I mean, you know, I'm glad they want community feedback, but are they really asking for community feedback? What's going to help me ensure that I will not get arrested? So this is something that the CDC and health departments and law enforcement all need to get together and work that out, because what I see is just going to hurt marginalized and disenfranchised communities. Because this goes back to state, local interpretations of methods and laws. How our law enforcement, you know, is going to act in LA versus, you know, Kentucky, and so, you know, what's going to happen with that? You know, how we all know law enforcement doesn't treat people with HIV very well, so, you know, during arrest, and in fact targets them, as in my previous slide. How is that going to look? That really needs to be thought out by the CDC and how they're going to work that out. Funding is not equal, rural versus urban. Who gets a chunk of the pie? I just mentioned it. Some health departments are very well funded and that, you know, have all the equipment to do this smoothly, or semi, you know, and also who gets a chunk of that pie versus, you know, a very small health department in, say, North Carolina that just puts a note on your door that you're HIV positive and you're not allowed to take it down. So, you know, who's getting a chunk of this pie? Outdated equipment, outdated methods, i.e. cultural stigma, can affect how data is input and tracked. Methods of mining such data can lead to deadly consequences for sex workers. You know, once law enforcement outs that you're HIV, you could be killed, and we all know this. We could be killed. People can be killed for their status. And so, you know, when we're already marginalized and work under criminalized situations, you know, it's and someone finds out you're HIV positive, with the social stigma and just, you know, the cultural stigma, just the stigma around HIV alone, because we still have that 1980s mentality. Most people aren't educated on it. They just know it's AIDS and you're going to die. So, you know, there's not, this just putting an increased risk in communities that work street economies, say, the trans communities, trans sex workers. And so you know, you can have some deadly consequences for that. And I'll just let out a story I asked of a friend of mine that one time, because at first I did have a problem with HIV and sex work, and she really, and it was my friend who and I asked her, you know, how do you work with HIV? Do you tell your clients? And she said, fuck no. And she goes, I'm not, and she's a black trans worker, so and working in D.C., and so she said, fuck no, and I asked her why, and she told me that she could die. You know, I'm not going to get killed. If I'm undetectable and I'm taking my meds, and this is the only U equals U I will shout out for. If I'm undetectable and I'm taking my meds and I cannot transmit the HIV, why would I tell my client so they could kill me? So you got to think about some things like that. And that really changed my whole perspective on HIV and sex work. It changed it completely around. So, in order to encourage sex workers for harm reduction methods, maybe sequencing and clustering, are not in the best interest of marginalized communities. Criminalizing condom use. Some places, if you have 2 or more condoms in a known area for prostitution, you're arrested. I mean, really? So that's a problem. Targeting, profiling, discourages testing, linkage to care, bridging, medication usage. It can dangerously backfire identifying clusters. So my big concern, and I'm not a scientist, but I am an expert on criminalization. Believe that, and so I have some huge questions for that. Huge. On how this is going to be played out. Because I'm 58, and I've watched a lot of stuff being played out as far as databasing goes. I mean, we'll go back to Nazi Germany if you want to go into databasing. In L.A., when they started databasing gang members, where two relatives could not ride in the same car together. You were arrested for two or more people sitting on a stoop in apartment. And so, using it, and then, like Octavia said, what happens if you go across states? Then you can add other criminalization in there. For escorting, you could get it for the Mann Act. So federal laws are starting to play in all this of what could actually happen if this goes horribly wrong. And my bet would be it's going to not go as well as the CDC would like to think it is by just throwing it out there and seeing what sticks. They've got to think farther than their ivory tower. I'm sorry, but that's all I've got to say. And thank you for letting me rant in a nicely worded webinar.
Thank you, Chris. I listen to your rant anytime. Thank you for giving us a history lesson as well, and bringing across some important points. So, from the sex work perspective, which cuts across all kinds of communities. And so, I want to say we're running a little over, and if you look in the chat box, you will see a link to register for the next webinars if you've got to get off, and a link to follow us on Facebook or if you want to see the recording. But I want to get right to our last, but definitely not least, panelist, my brother, Robert Suttle. Bring it on. Take us home, Robert.
Thank you, Vanita, and thank you to my fellow panelists for your presentation. I mean, I feel like you said everything, and there's probably not much else for me to say, but I will say this and in the interest of time, speaking on how communities, our African American community, experience policing and law enforcement. Just want to keep in mind that we are more affected by HIV than any other group in the U.S., according to what the CDC says, and that we also account for higher proportions of new HIV diagnoses and people living with HIV compared to other races and ethnicities. And so, how do we experience policing and law enforcement? I mean, it's pretty much in line with the prevention challenges that exist. I mean, we live at intersections of stigma, homophobia, discrimination policy that, put us at risk for multiple physical and mental health problems that have already been mentioned here, that may affect whether we seek or are able to receive access to care and treatment, including HIV testing, treatment, and other prevention services. And some of those factors that are specific to African Americans and also bisexual men that the CDC lists is lack of awareness of HIV status. 1 in 7 African American men or Black men with HIV are unaware that they actually have it. And so by that, people are not able to take advantage of care and treatment and may unknowingly pass HIV to others. Timely linkage to HIV medical care, low rates of viral suppression, and of course socioeconomic factors as relates to poverty, education, housing, and things like that. So when it comes to, so I say this all to say that, collectively, historically, or even intergenerationally, we have this trauma. Each of us who are living with HIV have experienced personal trauma events, which affects our ability to trust, have a sense of safety, or even a sense of who we are. Because many people once they're diagnosed, they tend to forget their dreams, forget their desires because of the stigma that comes with a person being diagnosed with HIV. People forget that they can live whole lives and be made whole. However, when it comes to surveillance, I have a few concerns that I have raised here as it relates to policing and law enforcement practices. It should come to no surprise that many states turn to HIV-related policies or criminal law to help limit the spread of HIV. I mean, there is evidence of, for example, there is evidence of disparities in enforcement of HIV criminalization laws related to geography, race, ethnicity, so on and so forth. Black men or African-American men are more likely to be arrested and or convicted of an HIV-related offense. There's an increase in diagnosis among people, African-Americans living age 25 to 34, and I find that interesting that according to the CDC data, that the increase in diagnosis among African Americans between the ages of 25 and 34. But did you also know that 1 in every 10 black men in his 30s will likely end up in prison or go to jail at any day? And I know that for a fact because I was 30 years old when I was facing conviction, and I was 24 when I was diagnosed with HIV. So I think that some interesting truths or revelations to that fact. And I'm curious to know how many other people who are either diagnosed in their early 20s, or even into their early or mid-30s, and perhaps how many of them perhaps may end up in a prison or jail or have that experience. Other concerns that I have about surveillance is the perception. This perception of African Americans that we are dangerous people, but this perception that we hide. Naturally, culturally, there are things that we don't discuss within our community due to stigma, homophobia, and discrimination and things like that. However, I like to think in terms of this surveillance thing is that I don't think we're necessarily hiding. I think a lot of us are really trying to manage and survive and cope. So I find it quite interesting that the CDC or the public health are feeling that they have to implement this robust process or strategy because they can't really find us or they can identify those of us within these clusters that are living with HIV and so forth. Another concern that I have is that only HIV-positive person is responsible for prevention under the law, it seems. And so I think that, with the surveillance, it's just going to be more of that type of thinking or understanding that it's only us that are responsible for prevention. And of course, those of us that understand the community know that that can't be possible. Other concerns is that policing and public health, I even say public health, have negative attitudes, poor knowledge, and inaccurate assessment of, for example, policing occupational risks related to HIV. And so I think that if they're planning to identify or connect with people within the community, that they're going to have to do better with changing their approach in terms of their attitude. And get more knowledgeable about the real risk and routes of transmission of HIV. Why the negative attitudes, I don't know. And again, it's tied to the perception, that we are dangerous people. And so when you make something a law enforcement, quite naturally, I think because of how they are trained, that they think that automatically you're wrong, you're negative, you're bad, you're dangerous, and so therefore you should be, handle accordingly. Other concerns is that how complicated and it is in terms of decision making that happens in the consensual sexual hookup experience within our community, where people willingly engage in sex that could possibly transmit HIV. And of course, that could lead to situations where there are contradictions in police reports and things, especially when someone who may or may not have disclosed their status or they may be identified as someone who is going in the community to, transmit HIV or whatever. But just like within the HIV criminalization, we may not know who exactly we contracted HIV from. However, with the way the laws are written and with the way the society handles, this issue, whoever we can identify first around us, we will pretty much think that that's the person that may have exposed us to HIV or maybe has transmitted HIV. But do we really know? Do we really know that individual actually transmitted HIV to us or absolutely exposed us to HIV to where we're really at risk? And so I just feel
Good point.
Yeah, I just really feel like with the increase in this surveillance, that we're going to have more of those situations happening, and therefore, as a result, more people will be prosecuted possibly. And, I've listened to the briefing by these sort of experts within the Trump administration talk about how we need to approach these communities with love and or compassion and things like that. And I don't see that happening. I really don't see that happening. And I don't think I don't think society or those persons that are going to be doing that surveillance are going to be in a position to offer compassion and understanding to people within the community, especially when they're trying to sort of end the epidemic, which I think, honestly, my personal opinion, that is a false hope because of if we're not addressing the issues, the racial injustice, or we're not addressing the social issues that put people in position of contracting HIV or finding out that they're HIV positive or living with HIV. There's no matter what type of program or implementation you try to implement, you're not going to end this epidemic, and you're only going to continue to further marginalize people. And of course, the numbers will continue to either stay stable, stagnant, or they're going to go up. So I'm just hoping that that by us doing this webinar, that many people that are not knowledgeable about this type of surveillance, that they will be knowledgeable, because I really see this going in a direction that's going to only increase more instances of criminalization and incarceration, particularly of African American people, and also the communities that have been represented here on this webinar.
Wow, thank you. Thank you, Robert. I so appreciate your sharing. And we're talking about the Black community. As a woman living with HIV myself, Black women represent 60% of all women living with HIV. And so when we're talking about targeting and we're talking about who are we talking about policing and surveilling, you're right. It's tending to be Black, Latinx, our trans sisters and brothers, and other marginalized communities. So thank you so much for that. Brian, I know we're a little over time. You had a question or two. I wanted to just humbly thank this panel because it's really my honor, Andy and I, to host this. And with Brian, you have a question you want to finish out with?
Yeah, we just have time. I know there's more questions and we'll have time to address, but we can get back to those of you who were not able to address via email. I think for the purposes of time, I'll just share one comment and then ask one question of the remaining panelists. The comment comes from a health department, and there was a concern. There's a lot of different folks on the webinar, from community, from health department, research, from science. So to keep that in mind, there was a concern that there might have been some misinformation as part of the webinar about what molecular HIV surveillance entails. And we're not going to go deep into that concern. I just want to remind folks on the webinar that the purpose of today's webinar, as the title says, is it's all about centering people living with HIV. So the purpose really was to talk about the perspectives of people living with HIV from various communities that experience policing, that are over-policed in the United States. And so those perspectives are valid, and we wanted to uplift those and start the series with those perspectives. This, of course, is a 4-part series. So part 2 is coming up and will feature Dr. Carl Diefenbach from the National Institute of Allergy and Infectious Diseases, as well as our very own Vanita Ray, who's with us today. So there we'll get some more varied perspectives as well, one from the NIH and one from Positive Women's Network representing the community. So just wanted to highlight that hopefully the perspectives that we've heard today are really educational for everyone. And if there's more information that communities need with regard to community engagement and education about molecular HIV surveillance, then that's a need that we can identify today as well. And we'll hear some more of that. On part 3 of the webinar series, we'll have Dr. Eugene McCrae from the Centers for Disease Control and Prevention, as well to talk about the CDC perspective on molecular HIV surveillance. So I just wanted to uplift that comment. And the question as well is just one question that we can ask for the panelists, and it's all about molecular HIV surveillance and community engagement. And the short version of the question is, why should communities that suffer under surveillance buy in or support engagement in molecular HIV surveillance? So I'll pose that question to the panelists.
Hi, this is Octavia. First, I think our community, all of our community needs to be brought up to speed on what HIV molecular surveillance is. I, as a woman of trans experience, try to keep myself up to date on things, but honestly, I didn't have a clue about what it was until I was asked to be a part of this webinar. So even though I know that molecular surveillance was used to track tuberculosis, I didn't understand the implications that it had on those living with HIV until I did my research and, again, until I was asked to be a part of this webinar. So I think these type of conversations need to happen more often, and people need to be made aware of all of the concerns. Because like you raised a question about someone saying the misinformation, I think where we were coming from, like you said, was about our concerns about it. And for me, it was about making sure that, again, people were equipped with the knowledge to ask questions, because I didn't even know this to even start to begin to ask questions, again, until I was asked to be a part of this webinar.
This is Chris, and I'll go further than that. It's not a concern. It's our reality. So when you get law enforcement and health departments working together, as in my first slide, I said that law enforcement was known to smash your meds on the ground, let other sex workers know that you're positive, arresting clients and letting them know, arresting them for carrying 2 or more condoms, non-disclosure, and I mean this is interpreted from different states how they interpret the laws, but some laws are really harsh. I mean, we still have spitting here. So, you know, the laws are different, but it is our realities. So you know, I'm sorry if I offended anybody, but that would be a first. But, you know, this is our reality. This is the reality sex workers live with. So as Robert said, I don't see this as the great hope. I see it as this could go terribly wrong. Thank you.
Any other panelists want to respond?
No, I don't want to respond. I wanted to appreciate actually the people that got something out of this webinar. We are the community that experiences HIV on a daily basis. And like Benita said, you know, it's not left in the desk or at the desk or your office. And so I feel like that as a person living with HIV, someone who is responsible and highly sensitive of my community, I feel great about speaking from my perspective about an important topic that hasn't really been disseminated. The language that is used at the moment for molecular surveillance on HIV is actually not even transformed for a community to digest. And so expect that people may have different interpretations of things, but overall, the important is that we want to be part of the solution, and we wanted to establish a positive and a productive dialogue that has not existed. And so we are initiating that, and I'm very proud of it. Thank you for having me, and much love to my colleagues and friends at the webinar and those who were listening to us. Thanks.
Thank you. And again, I thank the panelists. There's more to come. Remember, this is just part one. Let's own something here. I've been involved with the NIH research, developing ethical guidelines for almost 2 years now. Involved in HIV criminalization work for a number of years. Been living with HIV for 14 years. Been a Black woman all my life and seen what I've seen. Let's just say, until the HIV community began to push back against this science and what was already occurring, no one, CDC and others, were not coming and speaking to us. After there was some pushback by the HIV community, and we'll give the CDC some credit, they held some webinars that allowed us to introduce the things that they've been doing, and then had some listening sessions where we were able to speak, but there was no response to it. So although we are happy to continue participating in that, we want a kind of venue that we get to speak and express the impact on us, as well as we are interested in a dialogue and not a community process that is after the fact and that we just get to check the box and we heard you now, but the people keep saying the train is out the station now, where this should have happened before. And if there was any misinformation here, I would say it's because people did not come to the community in the first place with the information, and we've had to teach ourselves and get involved in our own ways to learn. So we welcome the dialogue. We invite you to part 2, 3, 4, and we hope that there will be some continuing dialogue after that. And we don't pretend to know it all, but we do pretend to be the experts of our own lived experience. So thank you, Brian. Thank you to the partners. Thank you to all who joined. I am honored. And on behalf of Andy, who had to get off, I know he feels the same way. So thank you all, and have a good afternoon, everybody. We're not done yet.
Thank you all. Have a good day, everyone.
Thank you. Bye.
Alrighty, bye-bye.
Bye-bye.